It's 12:30. We got the recording going. That's great. And I'm going to turn it back over to Lynn. She's in charge of the afternoon.
All right. Well, you've heard so many great things just over the course of the break, and thanks for hanging in there and the great discussion. It was really fun to listen in on. And this network is amazing. We all share resources with each other, and it's so, so important. And so as we pivot to the afternoon, we're going to start talking about state issues and state legislative session. And before we get to the state session, we get to some ballot pieces. So I wanted to just share my screen really quick because this might look familiar for some of you. If you've looked at your voter's guide of
Lynn, I'm so sorry. I was trying to let someone in from the room
That's
and I
okay.
accidentally muted you.
All good, all good. I was like, did I mess up? Zoom crashed on me earlier, so just FYI, hopefully I stay in here. This might look familiar. If you've looked at your voter's guide, it will be on your ballot. So we wanted to make sure you got information about this ballot measure and the Senate Joint Resolution 8201. And so we are joined today by Mark Stensager to talk about this. So I'm going to stop sharing, but I wanted to give you a visual because this is what you'll be seeing on your November ballot. So I'll pass it over to you, Mark.
Thank you, Lynn. It's great to be participating in this session. Brings me back to old times. I was the King County Area Agency on Aging Director 50 years ago. So this is all wonderful discussion. I've developed a statement. This is a pretty complicated issue. So I will read a statement that describes 8201 and then be open up for questions. I'm a member of the Long-Term Care Services and Supports Commission, which oversees the state's long-term care benefit program called WACARES. However, I am speaking as a private citizen today and not as a representative of the commission. I am strongly in favor of Senate Joint Resolution 8201, which would allow the Washington State Investment Board to invest a portion of the billions of WACARE dollars in stocks rather than be limited to conservative investments such as bonds and treasury bills. It is anticipated that 70% of WACARE funds would remain in conservative investments if this proposal were to be adopted by the voters. It should be noted that SJR 3201 passed the State House and Senate by overwhelming bipartisan votes. In considering this ballot measure, it is important to understand the role and reputation of the Washington State Investment Board. The WSIB is an independent, nonpartisan board that manages investments for 17 investment plans in Washington State. Under this board's management, the average return is 8.1% annually. This is well above the return that would be generated if the board continues to be restricted to conservative investments for WACARE funds. Independent actuaries estimate that if the return on WACARE funds could increase by only 1%, it would generate an additional $57 billion over the next 50 years. The risk, in my opinion, is minor. Understanding history helps. No bear market where returns have declined more than 20% a year has lasted more than 3 years since World War II. In addition, the investment board has a history of prudent financial management, and that will continue. Under the current conservative investment policy, the WACARES benefit expenditures may exceed incoming revenues by 2050. Passage of 8201 should allow premiums to remain stable and may allow benefits to be expanded. I have served on the Long-Term Care Commission for 2 years. It has been an exciting thing to watch as we develop this program. Next year, many disabled residents will start receiving benefits, and that number will grow over the next few years. This program is the first of its kind in the country. It is hard to predict the use and cost of services over the next 50 years. The passage of 8201 should give us needed flexibility as we manage this innovative program. I'm open up to any questions.
I'm looking for questions. Any questions for Mark?
Yes, Rick?
Mark, is there any provision in this on how those funds will be applied? Or is this
No,
just a matter of generating more funds?
No, that's up first of all to the commission, who's ever there in 50 years, and the legislature. So we serve in an advisory role to the legislature, and proposals for adjustments in benefits or increases in premiums would be recommended by the commission.
Thank you.
And it looks like there's a question in the chat from Eileen. What is the portion that would be allowed in the equities markets? Do
Well,
we know?
we don't, but the experts, the conclusion, the investment board chair is not going to tell you exactly what they're going to do, but certainly the experts would agree. This is has been a very successful investment board, prudently managed for many years. The general estimates are, under kind of a general conservative philosophy, is that no more than 30% would be invested in equities. And that reflects the investment pattern, the very successful investment pattern that this board has had for many years.
Thank you. Yeah, I know those of us who are working for government or might be former state government, if you get benefits through Department of Retirement Systems, it's the same group that's investing that
That's
funding
exactly
as well.
right. That's right. What's great about this program is, unlike so many things you're talking about today, this is unique to Washington State. This is funded by Washington State. So no congressional actions are necessary to support this program, which is a delight to hear in the context of the current environment.
Right. And definitely as we think about walk cares, I know for many of us, you're probably really aware area agencies on aging were really involved in the passage of walk cares and making sure we as Washington State were one of the first in the nation to get our first public long-term care benefit. And we're all actively working on implementing walk cares right now.
Yes.
So every AAA around the state, we're ready for go live in July of next year. And those of us who are serving Spokane and then Lewis, Mason, Thurston are getting ready and geared up for the pilot that starts in January.
That's right. No, the partnership is very strong, and thank you for your efforts. There's going to be a pilot that will start in January, just to make sure we have the bugs out of the system. This is, you roll out a program like this, and it's not always easy. So to have a little demonstration project to start with is helpful.
Great. Any other questions? Okay. Well, there we go. Cindy, please go ahead and unmute.
Hi, I don't know if this information is available, but how much do we have in the system now for the WellCare care fund?
Well, it's I'm not exact. It will, by the end of when we start paying benefits, it'll be close to $1 billion. Billion, that's with a B. And we we're accruing a lot of money. Now we'll begin distributing benefits to some segments of the population that are older and disabled, but the full benefit rollout will not happen until 2033. And it's at that point that we'll start spending quite a bit of money. And it's why some of the estimates are by 2050, the benefit expenditures may exceed the revenues that are coming in through the monthly tax that everybody who's working in Washington pays. But it's a fairly significant amount of money.
Do you know how much it's projected to increase as the system is created right now at this moment every year?
Well, I don't have that off the top of my head, but we have engaged actuaries.
Mhm.
Millman Robertsons are doing actuary tables out for 75 years. And so they're making estimates as to where the benefit payouts are and the number of people that are going to be enrolled and the number of people that use the benefits. Now, to be eligible for the benefits, you have to have issues with at least 3 activities of daily living. So not everybody is going to be able to use this benefit. It has to do that's a classic eligibility requirement for people who are using long-term care benefits. So it's not going to be universally available, but boy, when you need it, you need it. And if you've got those kinds of conditions, you've got access.
Thank you. I appreciate your
You bet.
answer.
Okay, any other questions? All right. Well, thank you so much, Mark. It's really appreciated, and thanks for bringing your expertise to this group and all of the work you're doing on the commission, because I know that is a whole bunch of work in and of itself. So thank you for bringing voice to all of our concerns to that commission and just all of your effort and advocacy all over the years. So thank you, Mark.
Thank you, Lynn. It's been a pleasure.
All right. So the next item we want to make sure we get some time to cover is kind of setting the stage for next state session, which starts in January. So we have with us our wonderful legislative liaison for W4A, the amazing lobbyist, Kate White Tudor, and she's going to guide us through setting the stage. What are we looking at in 2026?
Well, thank you so much, Lynn. Can folks hear me? Looking for some nods. Yes, great. Thank you all. And thank you for your patience on a very long Zoom call. I must say I've listened in and it's been really informative. So thank you for sticking with us. So the legislative session will start again the second Monday in January. This year, that's January 12th. And this is our short legislative session. It is just 60 quick days. And they will adjourn at the end of the legislative session on March 13th, if my counting is correct. I've literally counted 60 days on the calendar. So this is the year in which they adjust the budget that they adopted for the 2-year cycle in the beginning of 2025. And the short session is typically the session where they may pick up some of the bills that didn't pass last year. They may pass some more if necessary to make the budget work, or if there's a compelling issue that has been brought to their attention or they feel like they need to campaign on it. But legislators are very much thinking about their re-election campaigns in the fall of 2026. That is when every member of the House of Representatives is going to be, their seats are open for election again, and half of the Senate. So this is like the short session, and they're all going to be eager to hit the ground for their campaigns after that session is done. The budget is going to be a big deal this year. We are required by the state constitution to maintain a balanced budget, which means that the taxes or revenues that are collected by the state need to match up with the spending that the legislature decides on in the budget and in the statutory obligations that they have to fund state programs. Last year, they had a shortfall. That's what it's called when there's not collecting as much as we need to cover the commitments that the legislature has made for spending. And they did raise quite a lot of new revenue. But this year, we are actually facing even more profound budget challenges. I know you heard a lot of doom this morning, and I'm going to echo that doom in how we see it reflected in the coming legislative session. Some of our very profound challenges come from the tariffs that are going to cost the state or cost revenues in the state up to $2 billion in the next coming 4 years. We have some significant challenges with court judgments. There's over $500 million that have been paid into court judgments against the state in the last 2 years. A lot of that coming from a change the legislature made to open up the capacity to file lawsuits for childhood sexual abuse against the Department of Children, Youth, and Families for incidents in the 1980s and 90s. So these are very, very old claims that were past the statute of limitations until they changed the law. And so now there are people who went through horrible experiences back in their childhoods who are making those claims, and the courts are awarding them significant amounts of money, and that's part of the state's obligation in the budget. The state has also been generous to its employees and school employees in the collective bargaining that's been done and funded in the 2025 budget. And of course, there continue to be programs for folks who need support. And at least last session, the legislature made significant investments in senior nutrition and other nutrition programs. And the federal changes that you heard more about this morning are going to require a lot of investment from the state to even sustain the remaining SNAP benefits, for instance. There's just a lot that the state is going to have to put in on its own money to sustain lower levels of federal assistance than we've had before. So the obligations to spend money are rising. The revenue that folks anticipated from last year is not coming in the way that they had forecast. The latest Revenue Forecast Council meeting was in September, and they say that we are down almost $1 billion compared to what we anticipated when we passed the 2025 budget in the looking into the future. The national economy has slowed. I'm sure you've all felt it and sensed it. Some of the taxes that they created last legislative session are being challenged in court. Our real estate sales have slowed. Our sales tax collections are down because people are anxious and not spending as much of their disposable income on things that are taxed. So there's going to be a really tough problem for our legislative budget writers in the coming session. I do not envy them. And as we were prepared this morning to say, like, look back to the difficulties we went through in the Great Recession with the budgets of 2009, 2010, 11, and 12. They had to make some brutal choices. And people are remembering those brutal choices and trying to do better in their plans for this next legislative session. We have certainly heard from the rector and other leadership that they are trying to preserve those programs that people depend on for their health and safety. They are trying to preserve programs that have infrastructure that cannot be easily rebuilt. They're trying to prioritize basic needs. So we're going to continue to advocate as zealously as we always have and connect you to opportunities to ask the governor to fully fund our health homes program, to fully fund the nutrition program and not cut back the commitment they made last year, and to preserve the other safety net programs that we know so many of our community members depend on. It's going to be tough. There will be cuts. So I just want to thank you all in advance for your courage and your engagement, because we are going to have many opportunities to present to you to engage and help share the message of the meaning of these programs, this funding, the services we provide, the people who depend on them, and your passion in legislators' districts for caring for the folks who need it most. So I'm happy to answer questions. I also don't want to take up too much time. I know, I guess we're a little bit ahead, but Lynn, how would you like to proceed from here? That's what I got.
Yeah, if we want to start with questions, and and see there. And if there aren't any, then we'll go straight into health homes.
I appreciate the clapping
So,
hands. I was like, oh, there's a question, but no, it was just clapping. So
well, thank you, Kate. And we all
someone's gotta have
appreciate
a
you and the work you
question.
do.
I mean, I'll stay here for questions if they come up. I put some information about the ballot measure into the chat. Please click through and read more information on this initiative. It's this resolution. It's really important. I mean, my personal statement on it is we are using the investment board to invest things for college savings, and generally that's like about a 18 to 20-year time horizon. Whereas WalkCares is closer to a 50 to 70-year time horizon. It makes absolutely no sense for us to leave that money in the state's equivalent of a checking account. It should be invested. You all know that your retirement savings need to be invested, and our long-term care funds need to be invested to grow and to give us more resources to make that benefit robust. So please spread the word. Thank you.
Yeah. Awesome. Thank you so much, Kate. And definitely, yes, spread the word. Like I said during break, you're our ambassadors as AAAs. We depend on you to get the word out, because especially when it comes to resolutions like this, as government agencies, we can't take a position as our agency, so we depend a lot on advocates and organizations like W4A kind of raising that voice and getting it out to more people. So thank you all. All right. Well, I will transition us into health homes. So as Kate mentioned, one of those budget asks that we know is W4A is one of our priorities. So as area agencies on aging, we will be advocating for, and this is the only one with a dollar amount to it so far, it's the health homes program. And some of you might remember health homes. It's come before this group at different times to ask for rates to get adjusted, to make sure the program keeps going, to continue the program. And we're joined today by our wonderful partners at Bridging Care. So we said, let's invite Mary to join us, because she has a wonderful story about the program and how it's impacted her. She works the program, she does care coordination, and many of us across the state do this service because we want to make sure people get the care coordination and help they need. So I'm going to share my screen and give you a few context setting slides first. So let me get this shared. Okay, so just thinking about health homes. So thinking in terms of this is a legislative ask. So this will also be reflected. We've got a 2-pager that talks about the program. So these slides are actually straight from that 2-pager. And we'll have that on the Aging Washington website very soon and have it ready for advocates as they start meeting with legislators. So Health Homes provides face-to-face care coordination for people who are dual eligible, so they're on Medicare and Medicaid. They might have Apple Health only. We also get to serve people who are Apple Health only, or they might be enrolled in a dual special needs plan. So that's a Medicare Advantage plan that's targeted to members that are both on Medicare and Medicaid. And when I say face-to-face care coordination, care coordinators go out and visit people in the community, see them face-to-face every month. They build a relationship. They find out where are they living, what is their life like, what are their challenges, and help people navigate challenges. So we know care coordination, sometimes there's a perception that it's a phone call and somebody's calling to schedule, your follow-up with your doctor. It's not that. This is intensive, one-on-one help focused on that individual and what their goals are. So what's going to help them, what's going to help their health, their services, their well-being. And this is a program that has reach. So we serve over 11,000 Washingtonians today. So this is a wildly successful program, and we'll get into that data. It also represents over 60 community-based organizations. Some are area agencies on aging, some are medical, some are community action agencies, mental health agencies, because this is a broader population. There's lots of people that really, they have high spend. So they have lots of chronic conditions. They've been in and out of the hospital, in and out of the emergency room. And so they're people who really, really need help and assistance. And it's part of the Medicaid state plan amendment. So it's approved by Centers for Medicare and Medicaid Services. This last session, the legislature continued funding for the program. We still get federal match, but unfortunately we don't get those shared savings from Medicare anymore as a state. So the program last session was in jeopardy of shutting down by the end of this year. We were able to get it extended through December 31st, 2026, but we still have a 6-month funding gap we need to close. So that's why we're asking for this session. And here's some of those data points. So this is part of what we're talking to the legislature about, is that this program actually creates cost savings. So not only does it have reach, it is highly impactful. It really, really impacts the care people get, the services people are getting, their health. It decreases the probability somebody's going to get admitted to a skilled nursing facility. It decreases long facility stays because people actually get the assistance they need to go back to the community. We see a decline of 20% in outpatients emergency department visits and 37% for inpatient admissions. So as you can imagine, the state needs to think about, wow, they're getting some pretty significant savings to the Medicaid program from this. So it isn't just saving Medicare money, it also saves Medicaid money. So thinking not just of the human impact, but just the financial impact of when you're providing human-centered, person-centered care coordination and meeting people where they're at and assisting them to get the resources they need. And, you know, there's lots of health impacts. It's very, very well proven. And we know this session, thanks to Healthcare Authority, in their decision package, they've shared with us how much it would cost for that 6-month period. So our ask this session is $6 million general fund state plus the $8.35 million federal match to keep the program operating for the full biennium. So it's to close that gap. That'll help close the gap, get us all the way through June 30th, 2027. Gets us that last 6 months. And then we assume we'll be back next session to try to get sustained funding for this program. And it's one of those, we also want to talk to legislators about impact. So if this lapses without funding, they will see an impact in Medicaid costs because people depend on these services, and the people that are getting reached by this service, you know, it really does save lives. It has a major impact on what kind of care people are able to receive, what care they can get into that they might not have realized is even available. And then losing this funding will really destabilize care networks that have been built over a decade. So all of us who are care coordination organizations, whether we're an area agency on aging, a mental health organization, we all depend on this funding to actually get us the level of care coordination we need for some of our most at-risk people we're serving. So I know as an area agency on aging, we look at our caseload and, you know, we do case management, but it just gets to the point where if I have a caseload of 80 people or 75 people, can I meet with every one of those face-to-face every month and really build that relationship and make a difference and get all my assessments done and everything else? No. So this really helps add when somebody is experiencing issues. We see, can we get them onto health homes so we can really get somebody to have boots on the ground, building that relationship, working on things over time. So with that, I am going to stop sharing my screen because I know that's a lot of information, but I wanted to get to stories because I feel like stories and experience has an impact. And I really wanted to ask Mary if you'd introduce yourself. Tell us about how you work with health homes and what your experience has been.
Thank you so much, Lynn. I was struggling with my unmute button. It's such an honor to be here. My name is Mary Munjua. I'm the Director of Care at Bridging Care. We are a care coordination organization and we offer purely care coordination. We have just gotten licensed for behavioral health, so we're excited to be growing. We currently have, I think we are the biggest CCO right now in Washington State, and we cover about 2,200 and some members of the 11,000 members. And majority is Medicaid, but we do have about 30% who are Medicaid, Medicare dual eligible. Lynn wants me to share my story because I think it's a very impactful story to just show the benefits on an individual, for a family and on an individual level, as well as the dollar savings that health homes has been able to manage. Health homes for me is not only exciting because I am a care coordinator, but it's also because my little boy was in the health home program for a long time. When we had Matthew, he had a lot of health complications that his primary care doctor could not figure out. Nobody really wants to probe a newborn. So initially we had this, she kept on thinking maybe he had GARD and he had different diagnoses. And for a long time, he became very, very sick. And we ended up in the ER often. The ER became our, the place we would seek our help. And that even when we used to call her, she would say, just rush him to the ER, let's get him into the NICU. So often we were in and out of the NICU trying to figure out what was wrong with him. I think by 9 months, he had severe malnutrition, failure to thrive, severe feeding difficulty. He refused to eat completely. And we just couldn't figure it out. He had trouble breathing. He couldn't sleep, had severe eczema. He was a very, very sick child. And for me, it was extremely depressing because I am a physician by profession and I had been practicing for 10 years. So I never thought I would have a child that I am unable to diagnose and unable to take care of. And it just became very difficult. Even when we started getting referrals to specialists, I didn't know what to do with them. I couldn't just be a mother. I had to advocate for myself. I had to fight for my child and figure things out that I couldn't at that time. It was a very frustrating situation for me until we were referred to the health home program because of recurrent ER visits, because constantly in and out of the ER, in and out of the ER, in and out of the NICU. And then PQ when he became a little older. So when we got my care coordinator, we set out goals. We're like, this is what I want. I want to find out a diagnosis. I want to be able to reach out to these doctors that I haven't been able to reach out. I need somebody to help me call and make these appointments. And she got us a list of everything that we needed. She scheduled those appointments. She helped us, she would ask questions that I had not even thought about. At that time, I didn't have a car. We needed to go with Uber. She would ask, should I schedule rides for you? Like, she gave me somebody to walk with and know that I'm not alone while I'm doing this for my child. And we got a diagnosis. We started getting treatment. We got the sleep medicine doctor who figured out why he can't sleep. We got the ENT. Then he got his surgery for his adenoids, which had completely blocked. That's why he couldn't breathe and kept on having snoring and mouth breathing, sometimes apneic attacks. So that was sorted out. We got the gastroenterologist. We got him scoped. They figured out he had severe eosinophilic esophagitis, and that's why eating is painful. We got the dietitian. They figured out what soul nutrition to give him. It was such a long journey when I think about it, and I've shared this with Lynn and Kate before. One day we got a bill from the PQ that was $500,000 US, and I come from Kenya. I changed that into Kenya shillings. It was shocking for me just to imagine how much that money is and how many people in the village would be able to feed for a month. And that was just one visit. And we kept constantly in and out of ER, in and out of PQ. When we look at the the ER visit, I was shaking. 4 hours in the ER, and we have a bill of 16,000 because we got an MRI, and then he probably got a CT scan, and then he got something else. And you look at the bills, and I'm thinking, a bag of IV fluids, how is that $1,000? And at that time, my head kept on changing everything into Kenya shillings, and it's mind-boggling. So we have not been in the ER with Matthew for the past 2 years. He is doing extremely well. He's on the 50th percentile. He was never on the track, on the path thing. He's at the 50th percentile for his weight. He's 50th percentile for his height. He is a purple belt taekwondo child. He got a gold medal on his last tournament two months ago. He got support to go to a gifted school because he tested gifted. He's exceptional. He's at 6 years old and he is doing 6th grade mathematics right now. We would not have gotten here without my care coordinator. We would not have gotten here without health homes. I was laughing the other day and I said, who knows, maybe I'm raising a little Einstein, right? Maybe Einstein would not have made it. And I am so excited. Health homes is a major passion for me because I've seen the change. Since we haven't been to the NICU or ER in 2 years, I think we've saved just the state and Medicaid like $1 million in just the last 2 years. So if we're looking at just the dollar, how much money a health home member has saved Medicaid, it's a lot. And that cuts across from Medicaid to Medicare as well. And for families like my own, I'm able to work. I am able to manage other care coordinators who are saving lives every single day. A lot of people ask me why I don't want to go back into practice and, become a physician again. It's because I think what I'm doing is even bigger. We are standing in the gap for things that other people cannot see. And I'm extremely proud of what each of you is doing for everyone in this state. So thank you for the opportunity to share my story. Thank you, Lynn.
Thank you so much, Mary. It's just such an amazing story. It's one of those, I think we don't often recognize this program serves people across the lifespan. So it means not just, people who are in their later years and older adults, but infants and children and their parents. It wraps around everyone. And I think that's really important to think about too. Yeah. And I feel like your story is not unusual in what potential savings are there.
No,
I think about, not at all. I think of a gentleman that we work with that lives in Spokane, and he had kind of progressing dementia, and he primarily got services from the VA, but he was living independently in the community and in and out of the hospital, often would end up at Sacred Heart. He would be wandering out in the community. And when he met his care coordinator, Bev, she worked with him to build that relationship and to really look at, okay, where can we find you some stable housing where you can still have independence, but at the same time, maybe it's a safer environment. He was getting taken advantage of in the community he was living in. So was able to help get him moved, to get him into new housing. He's in assisted living now as his disease is progressing, but he was able to get a new wheelchair, everything so he can still be mobile and maintain his independence to get around. He's got a support system now he didn't have before. And when he wrote to legislators this last session, he talked about how he didn't feel like he was worth anything and he didn't have anything left to contribute. And the difference it has made to have that relationship, to, have somebody to help guide him and coach him and connect with on a regular basis, that he realizes I still have things to give. I still have worth, and so it isn't just I'm not in and out of the hospital. They're not picking me up on street corners anymore. It's also the helping people understand that they still have worth, they still have dignity, they're worth care, they're worth support, and that it's to never give up.
Agreed.
So, yeah.
Yeah.
Yeah. So I would love to hear, I know we've got other area agencies on aging and others in the audience. Does anyone else have stories they'd like to share about health homes? I know we're in process of collecting stories again.
And while we're looking for somebody to give us a story, I just have a story that has resonated and so fascinating in my mind. We had one of our members who was in and out of the hospital because she kept on falling. She was an elderly lady. I believe might have been an Adzwa from Clark County and Adzwa, maybe, I'm unsure. But she kept on falling and ending up in the ER. She broke her hip. And nobody could figure out why she kept on falling because we looked at the medication, everything was fine. And this was during COVID. And as soon as we were able to go back into the field, we had a care coordinator go into her home. It wasn't the medication. She just had too many rugs on the floor. So the care coordinator realized that because she's walking, she's unstable and she's not using her walker regularly. She had rugs. You know, when you go to some people's house, rugs, and none of them is pinned. So she would step on a rug and it would fall, and then she'd call 911 and end up in the hospital with a broken leg, with a broken hip. The moment the care coordinator realized that, we removed that, got somebody to remove the rugs and just put a regular floor like that, and she stopped falling. So it might seem like it's a little thing, but it completely changes the world for this member, because then again, there's no pain anymore. There's no falling endlessly anymore. And if we didn't have a care coordinator who would go into the house, we would never know that. The doctors thought maybe it was the drug, so they would change the dosage. People tried, but the actual cause was such a simple thing that somebody actually had to see on the ground.
That's amazing. That sounds very familiar. A story this group has heard before is one out of Bellingham and Northwest Regional Council, where it was a gentleman who was in and out of the ER, in and out of the hospital. He would get referred to home health, and they're like, he isn't answering his door, he's non-compliant, and was getting to the point none of the home health agencies would take him anymore. Like, nope, he isn't going to answer the door, we're not going to go out. And they discovered, after sending a health home care coordinator, he was hearing challenged and his doorbell was broken. So they got everything installed, was able to set everything up, and then he could get the care he needed, and it stopped all of those recurring ER visits. Oh, and I see Mike. Mike has his hand up from Southwest, and then Roy.
Sure. Thank you, Lynn. I would like to share a story. This was a couple years ago. One of our care coordinators were working with an individual who was deemed, non-compliant after multiple visits to the doctor. And so over a period of time of building the trust, the care coordinator and the individual, the care coordinator asked, well, why do they consider you non-compliant? Why don't you follow the physician's order? And she said, she was embarrassed and ashamed. She said, it's because I'm illiterate. And so that took this path down a completely different direction to where now the care coordinator can work with the doctor, get a better understanding of how to communicate and what are the options to communicate physician's orders and discharge plans in a way that is meaningful and is understandable by the client. And so just it's amazing how these little interventions have such an impact and a long-term impact. So just a great story. So thank you.
Thank you, Mike. And looks like Roy is next.
Thank
Good
you.
to see you, Roy.
Thank you, Mary, for sharing that those wonderful examples, and Mike, you as well. It's always baffled me. Obviously, the budgetary impacts of the state are really critical, but the fact that the intention is to help vulnerable people in our communities really should be top of mind for elected officials. I really am baffled at how little focus they spend on what's going on. My question was really for Kate, and it relates to, my assumption is that managed care organizations are also capturing savings from the health home program. And I'm wondering if Kate happens to know if our friends in the MCO world are helping us on advocacy on this piece.
I'm actually going to ask if Ryan Blackwell is in the meeting. I'm not sure, but he is the one who's the lead with the deepest level of expertise about the MCO's stake in this. My understanding is that it's a little bit complicated. They do realize savings, but they are also getting a capitation rate to include these services, and they're being required to contract with our care coordination networks that are managed by the AAA leads. So we have a relationship with the MCOs in which we are providing these services to their enrolled clients, and they're being required to review them all for their risk factors to do the assessments about whether their health home's eligible. I don't believe this is high on their agenda for advocacy. I think it has more to do with rates. Their rates are in a dicey position given the budget context. And since I am not seeing Ryan here to rescue me, I'm happy to follow up, but my sense is that we have a growing and effective coalition advocating for health homes, and that we don't actually want to get that complicated with the MCO rate debate.
Thank you, Kate. Nope, that sounds accurate. And that's where the state as well has helped provide some of that wonderful data around these are the Medicaid savings to try to help quantify and help make sure that we won't have health plans advocating at counter purposes either. So they're proving to them as well they are getting some major savings from these programs. And I see Laura has her hand up. Go ahead, Laura.
Thanks, Lynn. I just wanted to chime in with some stories from our rural area. We have one of the challenges with health homes is that our care coordinators have to provide auxiliary supports to a lot of our folks outside of the healthcare systems. We had a gentleman named Thomas over in Port Angeles who has Lewy body dementia. He had a dog, a lab of 14 years who had passed. He had had hallucinations earlier in the day before he had spoken to his care coordinator about seeing his dog curled up at the end of his bed. And when the care coordinator went out there, he was very clear that all he wanted was a dog again to make him feel safe and feel connected. And his care coordinator helped him find the right dog, got donated veterinary services because he wasn't going to be able to support that. She was able to get donations from the local pet stores for toys and leashes and all that. And it's really helped him a lot in terms of just feeling safe at home, of having that trusted companion while he was navigating, as he was progressing through his disease of having hallucinations and all of those fears that come up with that. And for folks who have been living with dogs their whole life, that was the one piece that really helped. Additionally, we had another woman, Michelle at Port Angeles, who also had been helping her spouse navigate some health challenges, which can be hard, which was a lot of driving and all that. She wasn't able to take care of herself. She was also eligible for health home services. She had a lot of missing teeth. She wasn't feeling good about herself. As she was helping her spouse with his journey, her health home coordinator convinced her to go through the application process of getting new dentures, of taking care of her dental needs. And she's got a new smile. She feels like she feels 15 years younger. She's found pride again in her appearance. And it brings relief to her. And she has made it very clear that she is very grateful to this program. And again, this is a little bit outside of what we think of health homes in terms of what it does, but that folks can get a really personalized support in navigating their health and dental benefits and even social benefits when it includes like isolation with the dog and going down the path of disease. So I just wanted to share those stories. Thanks.
Thank you, Laura. Yeah, it's one of those, this program, because it's so person-centered, it's going to the person, where are you at, what's going on? Sometimes it's just getting into the house to see that it's the rugs, to see that it's the doorbells. Sometimes it's, oh, this is, you're struggling with isolation and it's companionship you're missing and you need social connections. And how do we build that? Whether it's the service dog or whether it's, you know, connecting them with the senior center or other places where they can kind of get reconnected with community. And it goes all the way to major chronic conditions, trying to figure out what's going on, coordinating multiple specialists just to get to diagnoses and get to appropriate care. It is the spectrum. And that's what I feel like is so wonderful about this program. It's not about we're here to authorize this service or to pay for this specific piece here or this doodly dad here. You know, it's around what does that person need and having the flexibility to help support that person in getting where they want to be. And I appreciate everyone who's shared stories. We're going to keep advocating for the program, obviously, but like I said, this next session, our big goal is let's close the gap for the next 6 months or last 6 months of the biennium. So it's that 6 million general fund state is the important dollar number to keep in our heads. That's what we're advocating for. And it's that little bit will have a major impact. And I can't imagine what would happen to the state if we don't have care coordinators doing what they're doing, because it really does make a difference. So I'd be happy to answer any questions or open it up for any more questions or dialogue about health homes. All right. Well, thank you, Mary, for coming and sharing your story and just sharing what Bridging Care does. So it's great. We've got a wonderful coalition put together. AERP is joining us as well. So we've got some more that are kind of joining to lend their voices to keep advocating for this program. Oh, go ahead, Jan. There you go.
What are the requirements for a person to be admitted to home health homes?
Yeah. So health homes, we actually look at, there's a predictive risk score that they use that looks at their kind of medical usage, chronic conditions. It compiles it all together. So we actually, as care coordination organizations, we get lists of people who meet that criteria from the different leads that participate in the program. So whether it's a managed care plan or in my area, we work with Action Health Partners, they get us lists as well. And we actively go and try to engage those people in the service. So looks like you're eligible. Let me tell you about the program. We also take referrals. So what a lot of us with health home programs do as well is if we're working with someone and we know they're dual eligible or we know they're on Medicaid and they've got really high needs, high medical usage, we can screen to see, ooh, does this person qualify? And then try to connect with their plan to get them connected to the service. But definitely lots of conditions.
I have a friend that I would like to recommend. So how do I approach that?
What area do you live in?
I'm in the Tri-City area, and so is my friend. Southeastern Aging and Long-Term Care. Yeah.
All right. I will defer to Lori. Lori can help.
We're a lead health home, and if you would send me that information, if they're interested, we can have Felicia, who runs our health home program, run that and reach out to the person that you have.
Thank you, Lori, and thank you, Lynn.
Oh, thank you. That's awesome.
Okay.
One thing, Lynn, I'm sorry, that I wanted to add about the health home program is that it doesn't, and Mary demonstrated that when she had, we were helping with health home, the care coordinator, working with her and her family and her infant. Really, health home spans throughout a whole lifetime. It's from that infant to up until end of life. And so we are really, and my care coordinators, they are really establishing these relationships with these individuals, but not only them, but their families. And so the ripple effect from what health home can actually do is far greater than just impacting the client themselves. It's really impacting the family. It's working with those single moms who are having a real tough time and in and out of the hospital because they have uncontrolled diabetes, but we're able to give them meal plans so they can treat themselves better in their health, but then also teaching and educating their child to eat better and have better nutrition. And so those are the types of things that health home can really do, is really just expand and really have that ripple effect within an individual's own community and or home. So it's a wonderful program.
Awesome. Thank you, Felicia. And thank you for everything you do for the program in your region. All right. Any other discussion or anything else on health homes? Okay. Well, you can expect more advocacy alerts on this. You will. We didn't do an email for everyone to do this time, but we will probably be contacting you in the coming weeks through your AAAs to do some sign-on letters is the next step. And thankfully, we have some of us have a wonderful meeting this afternoon with the governor's office and legislative policy staff to talk about the program too. Because as we look ahead, and as Kate said, the state session is around the corner. So I'm going to transition us here. Is there a financial eligibility requirement for health homes? So it is around Medicaid eligibility. So as long as they are Medicaid, they should be, and then the added chronic conditions or medical costs, that is the qualifier. So that is the common denominator. Everybody has at least Medicaid in some shape or form. They may also have Medicare and be dual eligible, but they always have Medicaid. All right. Let me get my PowerPoint here shared. So as Kate alluded to, part of what we're going into this session is thinking about protecting our safety net of services. So you've got health homes on one hand, that is the one thing we have a dollar amount to, because those decision packages around HR1 that we talked about this morning didn't have dollar amounts. We don't know the financial impact of those yet. We don't know if the state is going to take money out, going to try to replace some of those services with state funds, or what exactly is going to get proposed. And so as we look ahead to the session, we just know that there's going to be pretty significant financial pressures on the state budget. There's going to be less money. And whenever there's less money in the kind of economic conditions we're seeing, we worry about recessions. And as a state that is primarily funded off of sales taxes, recessions are extremely challenging times for programs that get state funding. So, you heard a little bit about the last recession. Just here's a few headlines from advocacy papers. A lot of us have been around a long time. So we remember going through advocating during those sessions and kind of what was at risk at last time. So these are just a few examples from W4A and AARP from 2011, 2012, when we saw huge cuts to long-term care programs. So many things we had to advocate and be really active with the legislature to educate around. This is the impact. If you do this, this is who's going to be hurt. And so the reason we don't have more specific asks at this time is we don't know yet what's quite at risk. We'll know more this December and later in December once the governor's budget gets released. So we know his budget proposal always comes out in December. It comes out after the November revenue forecasts. So they look at that to see how much money do we have coming in to come up with estimates. But if what we're thinking are significant financial impacts from HR1 plus revenues decreasing, we kind of look at what are those things in our safety net as area agencies on aging that could be at risk. And so we're starting to think about what is that messaging, getting stories, getting ready to share those examples, help people we serve have their voices heard as well to talk about these programs. So things that could be at risk is, you know, Medicaid long-term care. We could see increased caseloads or eligibility changes, which could decrease people's care hours. We know we'll see coverage that won't be available anymore for some of the people we're serving because they're refugees or asylees. We know there's going to be impacts there. So we can't quantify, we can't say this is the budget ask or this is what we need to have you tell people to protect, but we will very soon. But we know those are some of the things that have happened in the past and are always things that are at risk. And then what we also look at is what are those state-funded programs? Because we know if you're not bringing in federal match, or maybe that match went away with, you know, bills and everything else that's gone on, we look at, all right, what are those things we're doing that rely on state funding? Because those can always end up on that list of, all right, is this enough impact? Is it directly serving people? And we have to come to the table to defend those programs. So things like we had to do last session around care transitions, area agencies on aging, all are doing, helping people transition from hospital to home, stay in their communities, stay safe, connect with the right services so they can remain in their homes and not cycle right back to the hospital again. Senior Citizen Services Act, those especially who've been around a while might remember last recession, we had to talk a lot about here's the critical things this program helps. Is area agencies on aging. It's kind of our gap filler. It helps us match our federal Older Americans Act funding and fill some pretty critical holes in our community, and there is no substitute for that funding. So if that goes away, it means more pressure on local organizations to try to come up with fundraising and match just to pull down those federal dollars. Family and caregiver support. Our state puts a lot of money into family caregiver support programs over and above what the feds invest in the Older Americans Act Family Caregiver Support Program. Without that funding, we will not be able to reach as many unpaid family caregivers across the state. So we always know it's state-only funding. It can jeopardize the infrastructure. And same with kinship navigator and caregiver support. So families raising families or grandparents raising grandchildren. That's another one where it is completely state funded. We depend on those state dollars to make those programs work. Or the dementia pilots, you know, we saw a third reduction for those 3 pilot sites. If that funding goes away, then those 3 area agencies on aging have to go, okay, now how do we try to keep supporting what's a growing part of the population we're serving and trying to provide the right community-based services and supports. So there's a lot that could be at risk, and we just don't know yet what are those things. And so we're all doing our best to try to educate legislators like we always do, show up to town halls, talk about long-term care, talk about services, talk about how critical it is, how it avoids other costlier services like nursing facility care, how serving people at home is not only just the right thing to do for most people, but it's also less expensive and it's where people want to get their care. So we do a lot of education just in the interim. So definitely, as you're out and about, you probably are getting calls for town halls, whether telephonic or you might see your legislator might have coffee chats out in the community. It's always great to just pop in and talk about these are critical services. And we'll have more messaging as we get closer to session. So there's a couple dates I want you to make sure you save. So all of us who work with area agencies on aging, we work for our advisory councils to do advocacy days or lobby days, whatever you want to call them, every year. And we're targeting early in the session. This is like the second week of session. And the reason we're going so early is it's only a 60-day session, so you have to get to them early to make sure they still have the breadth and capacity to listen. And we know with health homes especially, and then just whatever comes out in that governor's budget, we know we want to get on point and get on message early. So definitely save the date. We'll have that advocacy prep webinar that we do every year with Kate, and she will help get us on message, on task. Here's the agenda, here's all the things to consider, and then get ready for those advocacy days. We're definitely encouraging, if you can make it to Olympia, to go in person. We kind of feel like this might be a year if you can make the trip. I know it's harder for some of us than others because we've got farther to travel, but if you can make the trip, it's great to do it. If you can't make the trip, virtual is still good. So it's getting out, getting to legislators, getting to aides even to get that message heard, because all of those relationships make a big difference. So save those dates. We'll update our advocacy agenda as we get that governor's budget, can process everything, and don't forget to sign up for those action alerts at agingwashington.org. If you've fallen off of the list, re-register again, make sure, check your junk mail, make sure it hasn't gone to junk mail, because we really do get a lot of messages that are really timely out during session. And Kathy and Rebecca are wonderful at kind of, whether it's federal or state, giving you enough background, but simplifying the message enough so you can get that message out. I know we'll have messages coming up on health homes, but I'm sure we're going to have more and more messages this session as we go ahead. It's just, there's too much going on. There's too many financial pressures, and we know it will take all of us making sure our voices get heard for our population and the people we're serving, and helping the people we're serving call as well, and email and share stories and all of those things, because it takes all of it together to really make a difference. And with that, I am going to stop sharing because I can't see anything when I share. All right. So I'm going to check. Yep, we've got in the chat here, Advocacy Days Prep Webinar. Those are all in the chat. And that link there to register it for advocacy alerts if you haven't. Can I answer any questions or anything else? Well, Kathy, I might get to just hand it over to you for closing remarks, and we'll get us out before 2 p.m.
That's great. Thank you, Lynn. Aren't we lucky to have Lynn? I mean, she's amazing. Look at how she keeps us all together, keeps track of all the national stuff, the state stuff, the advocacy messaging. Yeah, Rebecca and I just sort of send it out, but Lynn's really the brains of this operation. So I want to thank everyone for making time for today. I was looking at the participant count. We have not lost very many people. So you've really hung in there. And I know, especially on Zoom, it's a long day. But I hope you found it helpful. I want to just remind you once again, you will get the recording from today's session, the full recording. You will get the PowerPoints that were shared. You'll have information, reminding you about the upcoming dates. All of this will go to your AAA director, because we count on and then we're going to ask that they send it to everybody on the advisory council, because people who weren't able to be here today will still really benefit. So I hope you found this helpful, and as challenging as the times are, we know we're all in this together, and we know it's an important fight, and we're going to get ready for whatever comes ahead. And I think Lynn's right. If you can make personal visits to Olympia, that would be great. But look at how well Zoom works too, and it gives you much easier access to more legislators and quick visits. So whatever works for you. It's my pleasure now because we have done this as a joint event. I was looking at the numbers for almost 20 years now. W4A and the State Council on Aging have done this as a joint event the day before the Senior Lobby Conference. Way back in the day, if you remember, when we all got to be together in person. And so I want to give the last word to Dennis Wheeler, who is the chair of the State Council on Aging. He is also on one of the local advisory councils, so he also knows just how important that role is that we've been talking about for you today. So thank you, Dennis, for being with us, and I'll turn it over to you.
Oh, thank you, Kathy. I want to congratulate you and Rebecca and Lynn for such a terrific meeting. It's really held my attention throughout. I thank you all for being a part of this. It's so great to see advisory council members. I recognize names. It's great to see faces and put them together with the names. But I think the thing that impresses me most is that these are challenging times for older adults with those with disabilities. But you know what? Sadly, it's also a challenging time for the people that care for them. I've learned a lot of important things today. I really appreciated the breakout one. There wasn't even a breakout, it was a discussion during lunch. Would have liked to have done that even longer. I mean, I learned so much. But the important thing is now, what are we going to do with this information? I think each of us has a responsibility to participate, and a lot of us do that because it's testimony to what we do in our councils. But, it's our responsibility to participate, but it's also we have to accept responsibility if we don't. It's as advocates, I know we fight ageism, but I would submit we actually are fighting apathy. We talk about fatigue, and I think fatigue breeds apathy. This is a long, hard fight. People feel like they don't count. You can see that in the voting records. They don't feel they count, or they don't think they matter. And so I think that's one of the things that we try to do. I received something last week that really disturbed me. I received a notice last week that notified me that Medicare Part B will no longer cover telehealth visits. Now, how can that be? I mean, haven't we just been talking about all this, saying that this is the answer, a low-cost answer to help those people in rural areas that are in pharmacy deserts? I don't understand it. If it's so important, and here we are working in this state and every other state's working on trying to create a rural health transformation plan. And part of that plan is low-cost answers and reaching out people in rural areas. Wouldn't telehealth be important? Well, this has fired me up, as you can tell. I've reached out to my federal representatives, to my representative and the senators, and I think that I deserve some answers. I think we deserve answers, and I think they need to be involved in it. And I think they need to find out themselves what's going on. So I think, this is what we can do. It's estimated between 200 and 320,000 people in Washington could lose Apple Care coverage, and between 100,000 to 150,000 could lose their coverage through Washington Health Plan Finder. This is just horrible numbers. I mean, how can people allow this to happen? So I just can't be complacent about this any longer. And so I just want to let you know that I've appreciated this, but I want to share one last thing with you. I attended a meeting, appreciation meeting for Sheba volunteers. Full disclosure, my wife is a Sheba volunteer. Tim Smolin, who is the program manager, and he's part of the OIC, Oregon Insurance Commissioner. Oh, they're going in their acronym. He parted the meeting and said, I want you to know that we're going to get through this. We'll figure a way out. We always have, and we always will. And I found that really reassuring and offered some encouragement. And I think that's what we need right now, encouragement to participate and know that we can make a difference. So as Lynn has shared, our voices do matter, and I think here's a chance to do it. And it's going to be little fights. It's little things that you have to stand up and be counted. So thanks for letting me share. I do appreciate it.
Thank you, Dennis. Getting us all fired up too. I guess we get the gift of a little time back. And I really, once again, I just so appreciate your participation. And you'll be busy, as you can tell. You're going to be busy in your role as an advisory council member or state council on aging member or staff person or AAA director. You're all going to be busy. And I thank you again for a wonderful day together. And we'll be seeing one another in various capacities soon. Bye, everybody.